But I think that's enough of me, Simon, and Andrew, and the ghost of Perry Dybel. And it's time to welcome our first speaker. Now, what you may not know about these two speakers, if you haven't been following Twitter today, is they have already spoken at a conference today. They've both spoken at the same conference, and they've come here tonight to speak to us again. So would you join me in welcoming Hadley, who's going to talk about the NHS digital strategy?
Thank you. Cheers. Not only have we spoken, but I'm also not feeling well, ironically enough, for a talk about health. But my apologies, this is going to be a little shorter than I'd originally expected it to be. Also, to be clear, part of the reason that Terence and I both spoke at the same event this morning and are speaking at the same event tonight is that we are both on the same team in our day jobs. Maybe? All right, we'll do that one. Right, so if you have questions, I'm going to give my talk and then disappear and go to sleep. But if you have questions, Terence will happily ask them or pass them on to me to try to get back to you on. Right, so this is me. I am both a member of the W3C Technical Architecture Group. Dan, our co-chair, is there at the back. Do any of you not know what that is? Is that a familiar London Web Perf thing? Great, okay. So we look at web standards and we try to coordinate all the different working groups across the W3C. My day job since August has been as Chief Technology Advisor to the Secretary of State for Health and Social Care. And I will tell you why. How many of you have had a tech role in the NHS? Good large group, okay. How many of you have wanted to build something with NHS data or with your health data? A few more of you. How many of you actually tried? How complicated was it? It's not easy, which is really, really frustrating. So 10 years ago, I led the program to design and deliver this, which is Synapse. It's a structured social network for junior doctors as they rotate from hospital to hospital for London and the Southeast. All of my user research was showing that when they arrived, they were so plugged into jumping into patient care and actually doing their jobs that it took them a long time to work out who their colleagues were, what training sessions they should be attending, where the HR department is, et cetera, et cetera. All the admin sort of fell by the wayside. So we delivered Synapse as a very structured way of kind of giving you a sense of who's going to be around you, giving them an easy way of getting information to you, giving you a calendar, contact information, that kind of bog standard stuff. Great, we're filling a user need, fantastic. But we couldn't build anything once to run everywhere across all of the hospitals and GP surgeries in the southeast of London, or southeast of England, which is phenomenally frustrating when you consider that that's what the web is supposed to be for. Many parts of the NHS organizations were running, at that point, IE6 was a lot to ask for. And the governance trying to get the approval to have anything be accessible in multiple places was just crazy. Each organization had its own series of boards, and I think there's something like 400 of them, organizations across London. There's been a big reorg since, and there's probably the same number, but with different boundaries. That's a whole nother talk. Anyway, it really frustrated me because I know that we, as the world, we have solved this problem, and it just killed me that we couldn't use those skills and that architecture in the NHS. One of the biggest barriers and one of the biggest reasons for it is that patient data, our data as patients, is largely held in electronic patient record systems, which is a full stack, one big contract solution with a relatively small number of suppliers. There's some for GPs, primary care, and there's some for hospitals and secondary care. And as a result, the culture has very much set up that the NHS organization is used to the idea that the supplier will make all of the decisions, they'll tell us what we need, it'll be fine. And that has then meant that the contracts have optimized for that kind of stability. We've liked longer contracts, we've liked things not changing, because when things change, then everything breaks. Obviously with a full stack, you can't just change the application layer, you change the data, you change everything else, and then You have 6 to 8 weeks worth of debugging, and incidentally, this is the NHS, people die. So this situation is clearly not working very well as it is, and is also not easy for all of us who know how to build stuff for the web to build for the NHS. So it got me thinking about how this is the internet on the left and an approximation of NHS organizations on the right. Both are definitely approximations, but they're illustrative. On the internet and the web, we gather at standards bodies, everyone who's got an interest, everyone who's got a use case, and we figure out collectively how to do stuff. We all agree that this is how you're going to mark up bold in HTML. But we don't sit down with every developer across the world who's going to build websites and say, you shouldn't use bold that way. Why don't you try using it this way? And then produce best practice guidance on how to use HTML. We don't do that. We agree on the rules, we get out of the way, you can build whatever you want for meeting your user needs. Central rules, total freedom. It turns out the NHS is actually a lot like that. We have central rules in the form of law, in the form of guidance on medications from NICE, the National Institute for Clinical Excellence, in the form of CQC, who are the regulator for hospitals in clinical settings, MHRA, who are the regulator for devices, et cetera, et cetera. And then each layer of NHS governance and bureaucracy also gets to set a lot of its own rules, like in this hospital, this is how we treat asthma, care pathways. But within the context of those rules, any doctor or any nurse or any clinician has a lot of freedom about how they treat you because they have a lot of expertise. And so in setting those rules, there's always this constant sort of wrestling with how much is the right amount of guidance and the right amount of concrete rules to set versus how much do we let everybody crack on because they've had 15 years of training and then however many years of their career and they know quite a lot about what they're doing. So architecturally or conceptually, these are pretty simple, pretty similar models. So I came into this job with this problem in my head, really, really, really wanting to solve it. And one of the first people I met was Simon. Simon is an A&E consultant. Simon is also the National Chief Clinical Information Officer, but we'll put that aside for now. As an A&E consultant, Simon has told me countless times how frustrated he is that when a patient turns up and in A&E and they can't remember the names of their medications, or they know they've had a procedure recently but they can't remember what it was, they just know that they've got stitches in their stomach, he has no way of getting that information. It's inevitably in a system somewhere else in the NHS and probably in a relatively structured form, and he just can't get to it. So he's got to make do with what he's got. This seems kind of unfortunate, very unfortunate, and kind of ridiculous from a technical perspective. This is John. I did not get John's permission to use his photo, which is why he's hypothetical. But Gavin, if I'd known you were going to be here, I would have used you. You have a slightly different use case. But what John is asking for his startup, which is showing clinical research information at decision time, if you prescribe this drug, know that people who have the same characteristics as this patient have a 50% success rate with it, or a 20% success rate with it, or whatever information is useful. And what John really wants is an API. We have said that we want to mandate the use of SNOMED codes for diagnoses and a whole bunch of other clinical terms. And he said he really wants an API where you can send the code and get the plain English back. And he said, obviously, this is something that everybody who's writing code for the NHS is going to need. Why don't you just build it once and centrally? This sounds like a pretty bog standard basic tool for those of us who are used to spending our time with APIs, but it doesn't exist. My best friend Katie has 3 children, and for each of her children, she got a little red book. I'm sure many of you have been through this journey yourselves. In that red book is all of the clinical information for that baby. You keep it with you. You take it from midwife appointment to GP appointment to hospital to anywhere else you need to go. And given the things that I do and the things that I think about, she has ranted to me countless times about how ridiculous it is. Why don't they all just have this information? Why don't they all know what each other has done with my child? Why do I have to keep telling the same story over and over and over again? And then speaking as a developer, I keep thinking, why can't I have that data to play with too? In a form that isn't paper in a red folder format. And this has been Goldacre. He's the chair of our Health Tech Advisory Board. And he's also built openprescribing.net, which is a brilliant data analysis tool for looking at prescribing patterns by the clinician who's done the prescribing. And he's looking for things like the ability to show show the doctors themselves who's prescribing more antibiotics than others. So you can see that if you're an outlier, or indeed less, you can start asking yourself questions about whether your patient population is actually different and you need fewer antibiotics, or you need more antibiotics, or in fact you're overprescribing. Similarly, the NICE regularly comes out with guidance suggesting switching from one medication to another as the ideal treatment for a particular condition. Ben's open prescribing tracks how quickly everybody is moving to the new guidance, to the new prescription, the new medication, which then makes it really easy to work out who the outliers are. And if your job is to help get those rules through the system, you know who to talk to and how to start getting that through. Ben has done and his team have done all this with the prescribing data from primary care. This is prescribing data per GP. He can't get the data from hospital doctors, which is obviously a treasure trove of useful information, and among other things could give us some patterns and trends that could save us hundreds of millions of pounds. But he just can't get the data, so he's understandably frustrated. As we all know, as I'm going through all these user needs, I'm sure all of you are thinking, the web and the internet architecture can solve this. We know how to do all of these things. We just haven't done it in the NHS yet. So here's why this is so complicated. When I arrived in August, these 4 organizations were all making decisions about how the entire NHS should think about and work with technology. We had the Department of Health and Social Care, who get to work with Treasury asking for money. They get to set policy. They get to work with the Information Commissioner on policy for who gets access to what data and under what terms. They also have oversight of NHS Digital, although they hadn't really been using it much apart from checking the financials. We have NHS England, who receive money from the department after Treasury passes it across. They then set out the plans for spending that money and for distributing it across the NHS organization, the local NHS organizations. They set clinical priorities, and they do a few national services like the NHS app. But I think they've largely done those because there's been a vacuum. There's been no other kind of central point to think about national services. An easy point to build from, let me say. Then we have NHS Improvement, which has just merged with NHS England to further complicate things. But they are the authority that regulates spending for the NHS, and they can define what is the NHS. If a particular hospital is misbehaving or is doing terrible things, especially financially, they have the authority to say, you are no longer part of the NHS. We're cutting you off. Obviously, that's a pretty nuclear option, but they have a lot of levers to pull, and that's really useful for incentivizing the kind of spending and therefore the kind of ecosystem that we want. And then there's NHS Digital, who describe themselves as the NHS's IT department. They do some underlying services like the spine and the e-referral service that are national, and they also do varying amounts of procurement guidance and regulation and a whole bunch of different things that some of which are useful, particularly when you are looking at an environment full of large systems, many of which don't make a whole lot of sense when you're just trying to build something that's lightweight and web-based. So with this complexity of structure, each of these groups has their own sets of boards for decision-making, their own pots of money, their own control over everything. When Matt and I, the Secretary of State, and I arrived, we thought that one of the easiest things that we could do was to shift the default for the NHS communicating to us as patients from letters, which are really costly and expensive and certainly wind me up, I hate checking the post, to email, where the patient's happy with that. Shift the default and then make it very easy to opt out if you're much happier to get post. This should have been a really easy thing to do, but given that complexity, it took us 7 months to get it through. And that's not something that's particularly disruptive. So we knew that if we wanted to shake things up out of the status quo, we needed to not leave the center that complex. So we've created NHSX. I'll bore you with the bureaucracy in for a sec. The chief executive of NHSX is both a director general in the department, so that's the second highest level of rank, and on the executive board at NHS E&I, which is also the second highest level. So NHSX, which is then beneath the chief exec, is a joint unit between the two. It then pulls together all the levers for central spending, local spending, what we do at the center to build the ecosystem, basically everything we need to have in one place in order to sketch out a big picture of how the NHS should work, basically define not just using web and internet standards, but then also what we need on top of that that's specific to us, and actually make it happen. So we need to get to where everyone in the NHS and the various parts of the complexity of the NHS can play their role. We need to make sure that those who have freedom to meet their local user needs have the skills to do it, whether that's developer skills, whether that's sensible buying skills for commodity stuff. Many of them know what they want to do and are ready to go. They've just been tied up by the old system and the old bureaucracy. A lot of them are turning to us and saying, we want to do the right thing, we don't know what the right thing is. So we need to figure out how to help them in a way that is useful, but also not going to get in the way of them being creative and doing good things. We need to make it really easy to write software. Everything's got to be open source that we're paying for, or it's just going to be, all of our rules for how you code for the NHS are going to be tied up in procurement contracts, and that's never going to work. And we need to make it really easy and clear how you can use NHS data, both what the APIs look like and the documentation, and then there'll have to be some, there are already, but there'll still have to be some approvals processes when you actually get access to live clinical data. And we need to make sure that that's as smooth and quick and understandable as possible. We need to make it really simple to manage working with the NHS if you are a company outside of the NHS. I know many of you who I've worked with in the past or who are old friends have told me that you've kind of gone near the NHS and then decided this is so not worth it, and you've gone off to solve other problems. We desperately need to stop that so that it is just as easy to jump in and build something fun for health as it would be in any other part of the economy. So specifically, we're looking at the procurement rules, the rules that govern how you show that this actually works, where it's got some clinical impact. The way it works right now is that you have to do a little pilot in the trust and prove that this is effective with this population. You convince them, and then you go off to the next trust, the next hospital, and they say, okay, we need to start over. We don't trust their evidence. We've got to fix that. We need to break down this full stack idea that when you do a new thing or you buy a new system or you start something new, you get the entire thing in one contract all the way down to the servers. I'm not kidding. We are creating a lot of new servers, which is kind of horrifying. If we can get to this really simple conceptual stack of hosting and networks, data, applications, that then gives us so many more choices and really unlocks the ability to continually innovate and improve, particularly a lot of the stuff that all of you are doing here at London WebPerf. There's no reason why the NHS should be frozen in where they are, and a lot of the applications that I see on a regular basis really look like they were designed in 1982. We've got to move past that. So, our next steps, now that we have all the levers, we've got to work out exactly what this ecosystem should look like. So we need to sketch out technical architecture, which is why we desperately need a CTO. We need a whole bunch of user researchers, front-end and back-end devs, service managers, et cetera, in NHSX, and then inevitably we'll need many more of them across the NHS too. We both need to show everyone what's possible and solve some systemic problems, skunkworks teams that can just go after a thing that's getting in everybody's way. And we need to sort out how we're going to handle the standards question. There's a lot of existing standards, like the Internet and Web Stack, that we probably need to adopt wholesale. But then there's a bunch of more specific data standards for patient records and for a lot of NHSE stuff that if we can get everyone to agree, and I mean everyone across the NHS and the supplier base, that this is the best way to represent a blood pressure, or this is how we should look at and represent an empty bed in a hospital versus a bed that's occupied. Then we've got a whole bunch of standards that are freely available, which makes it so much easier to build solutions to all kinds of problems. And we have all kinds of problems and all kinds of opportunities to make the entire NHS flow better. So we are setting up NHSX as an organization, as an alpha, which is kind of hilarious given that we're bringing, I think, 250 people into it from the beginning who are coming from the department and NHS England and Improvement. But we are going to basically, we're currently working out what the first things are that we're all going to work on, and then we're going to have to iterate as we go, which means this might look dramatically different in 6 to 9 months. But that's really exciting. So that's where we are. You can contact me on Hadley Beeman or the whole group at NHSX on Twitter, and we'd love to hear from you, and we really, really, really need your help. Thank you.
One of the fascinating things for me about that talk is both my parents are doctors. And so my dad, who was a consultant in Obs and Gynae, actually wrote a cervical cytology database system when I was in my mid-teens on an apricot computer in DBase, if you know what that is. So NHS Digital is fascinating. If you fancy a new challenge, there's your challenge.